Okay, so here we go. Welcome everybody to our webinar on anal genital warts and recurrent respiratory papillomatosis, otherwise known as RRP. You are very welcome indeed. Thank you for joining us wherever you are in the world. We've called this webinar an overlooked issue, and we think this really is looking at an overlooked issue. In the discussion about HPV-related disease, we talk a lot about cancer, quite understandably, but we don't pay much attention, certainly in policy, to warts and RRP. And our webinar today is hopefully going to put that right, to redress the balance and to look at this rather neglected issue in terms of HPV policy and practice. Just a few bits of housekeeping before we go any further. So it would be fantastic if you could use the chat box to let us know your name, organisation, and where in the world where you're based. Use the Q&A box to ask questions and the chat box to make comments, share thoughts, etc. This will be an interactive webinar. We very much welcome your questions and inputs after the speakers, so please do take part. This webinar is being recorded and will be posted on our website, the Global Action on Men's Health website and YouTube channel, and the webinar will last 60 minutes. So thank you very much for coming. Our speakers today, well, my name's Peter Baker. I'm the Chief Executive at Global Action on Men's Health, and I'll be chairing the webinar. After me will be Professor Riaz Seedat, who's the head of the Department of Otorhinolaryngology at the University of the Free State in South Africa. Then we'll hear from McClellan, President of the Recurrent Respiratory Papillomatosis Foundation, RRPF. And last but not least, we'll hear from Samuel Anyula Gorigo, who's the clinical arm lead at Hoymas in Kenya. So we have a very eminent and expert and distinguished panel. So we really look forward to hearing what they have to say. This webinar is brought to you jointly by Global Action on Men's Health and NOMAN is an Ireland Race to End HPV, and forms part of a series of webinars we've been running over the last year or so, looking at different aspects of HPV as they primarily affect men and boys. And you can see all the webinars on our website or on Global Action's YouTube channel. Just a quick acknowledgement. Global Action's work on men cancer and HPV is supported by a grant from MSD and also by funding from NOMAN is an Ireland Race to End HPV, who, as I said, are our partners in this work. So I'm going to say a little bit about the epidemiology of anogenital warts because it's not covered by any of our other speakers. So I think it will be useful background. And in fact, there isn't a lot of global data on this. It's not easy to find, but I've relied upon a study by you, and you can see a reference to that work on the bottom right-hand side of the screen there. There's a recently published journal, a paper in the International Journal of Infectious Diseases. And what this concludes, the systematic review concludes, is that most studies looking at this find that males have a higher incidence and prevalence of anogenital warts than females, with the possible exception of under 20 or 30-year-olds and in some countries where the situation is reversed. But the graph you can see we've generated using AI from the data in the paper, and it shows pretty clearly that certainly in the under 30s age group, females have a higher incidence of warts than males, but then in the older age groups, males are more likely to have warts than females. We also know that men who have sex with men have substantially higher incidence of anogenital warts than heterosexual men, and HIV-positive men who have sex with men have the highest rates of all. There is a very high recurrence rate of warts. For males, it's, depending on which study you look at, between 13 and 42%. And males make, on average, between 3 and 5 clinic visits per episode. And I think we can see from that data that warts are difficult to treat and also expensive. we have good data from two countries, the USA and the United Kingdom, and the estimated total annual cost of treating warts in those countries is $365 million in the US and $59 million in the UK, and they're 2024 adjusted figures. But there are some serious evidence gaps here. We don't know enough globally about the incidence of warts, and that's especially true for low-income countries. And we also don't have enough data on the impact on men who have sex with men. So I hope that's useful background. But now we're going to switch attention to RRP, and I'd like to introduce our first speaker, Professor Riaz Seedat, who, as I said, is head of the Department of Otorhinolaryngology. No, I'd slip up over that. I was called it the Ear, Nose and Throat Department at the University of the Free State, South Africa. So Riaz, you're very welcome, and we're really looking forward to what you have to say. So if you'd like to open your slides, and I'll hand over to you. Thank you very much.
Thank you, Peter. Let me share my screen. Okay, are my slides showing? Just like yes, okay. So I've been asked to talk on the global epidemiology of recurrent respiratory papillomatosis, which is a condition that most of you probably haven't heard of before. But it's characterized by the development of papillomas or wart-like lesions such as this in the respiratory tract, particularly the larynx, which is the voice box, the vocal cords being most prominently affected. So it's caused by human papillomavirus. There's over 220 types, but the respiratory papillomas are caused by HPV size 6 and 11 almost exclusively, which are two very closely related HPV types. So there's two clinical forms, juvenile onset and adult onset respiratory papillomatosis, that we recognize clinically. So the juvenile onset RRP occurs with infection of HPV during childbirth from the mother's infected genital tract. And classically, it occurs in the triad of a firstborn child born by vaginal delivery to a teenage mother. And the incidence is almost equal between males and females. Adult onset RRP occurs as a result of sexually transmission of the HPV, and it occurs more commonly in males than females. So if we look at the incidence, sort of in South Africa, which is typical of most developing countries, the incidence of the juvenile onset RRP is higher than adult onset RRP, whereas in Europe there's 3 peaks, juvenile, then a bigger peak in adults, and then a third peak has been described in patients between the age of 60 and 80. And a more recent study from Denmark also found this high incidence of adult onset RRP, especially above patients above the age of 20 years, right to 80 and 90 years. So in terms of the clinical presentation, there's progressive dysphonia, which is hoarseness of voice, chronic cough, and then as it becomes more severe, the patients present with upper airway obstruction, and patients can die as a result of upper airway obstruction from the papillomas. Juvenile onset RRP typically presents between the ages of 2 to 6 years. And as I've mentioned, adult onset RRP occurs. There's 2 peaks in the incidence between 20 and 40 years, and then between 60 and 70 years. So this is what we see. There can be these small papillomas on the vocal cords, in which case the patients usually have hoarseness. When it becomes more severe, you can see actually no normal vocal cords present, and the patients have upper airway obstruction. So the only treatment is recurrent surgical removal like this of the papillomas. Patients need repeated surgeries to remove the papillomas until they eventually go into remission. And Some patients need over 100 procedures before and never go into remission. There are emerging medical treatments available, but these are very expensive, unaffordable in developing countries, and prevention of the condition is far better than curing the condition or waiting for remission. So in terms of the effect on the quality of life, it adversely affects quality of life as can be expected, places significant social burden on families and the affected children, and adult patients can be prone to depression and anxiety as a result of these papillomas. So the incidence and prevalence tend to be similar throughout the world, but this slide highlights that the incidence and prevalence of juvenile onset RRP is higher in developing countries than developed countries, whereas the opposite occurs in the more developed countries. HPV vaccination has had an important effect on RRP. The first study was from Australia, which found a significant decline in the incidence of juvenile onset RRP from 2012 to 2016, and this has been shown in further data that's come out from Australia. Interestingly, they had 7 cases in the whole country between 2021 and 2024, and just in my hospital, we see about 10 to 15 new patients with the juvenile onset RRP in a year. This has also been shown in the USA, where there's been a decrease in the incidence of juvenile onset RRP following the introduction of HPV vaccines, and this is more recent data, which also shows the decrease in the incidence of juvenile onset RRP. A more recent study that was published this year showed with the increased incidence of HPV vaccination, the juvenile onset RRP incidence has declined, with a correlation between juvenile onset RRP incidence and the HPV vaccination incidence. This has also been shown in a recent study from Denmark as well, the decreased incidence of juvenile onset RRP. However, if we look at the situation in New Zealand, the decreased incidence hasn't been found, and it's probably the authors of this article speculate that it's due to the fact that the HPV vaccination coverage of women is not as high as it should be, which makes the case for the entire population to be vaccinated against HPV to reduce population spread of HPV and the incidence of RRP. Another case study that we published from the Netherlands was a patient with adult onset RRP who had been vaccinated, but with a vaccine that did not cover HPV 6 and 11, and subsequently went on to develop adult onset RRP. So the main reason for HPV vaccination is to reduce cervical cancer, but the vaccines are also effective against other HPV-driven conditions. But unfortunately, not all countries include HPV vaccination into their national protocols, and very few include boys as well. And it's also important to remember that not all HPV vaccines include coverage against HPVs type 6 and 11, which are the types that cause RRP. So it's important to not only make the case for vaccination against HPV, but also include HPV vaccines that include coverage against HPVs type 6 and 11. So RRP, in conclusion, initially presents with hoarseness, but can lead to life-threatening upper airway obstruction. Treatment requires repeated surgical procedures as there's no curative therapy at present, and appropriate HPV vaccination can eradicate RRP, and failure to vaccinate against HPV types that can provide protection against RRP is possibly a missed opportunity in terms of healthcare. Thank you.
Thank you, Riaz. That was obviously a very clear and concise presentation. You stuck perfectly to time, so I'm very grateful to you on a number of fronts, and also for showing the very clear link between vaccination, particularly at high levels, and the decline of RRP. I think that's a very important lesson for all of us watching today. So thank you very much indeed. If you have any questions for Riaz, please post them in the Q&A box, and we'll come back to questions for all the speakers after they've all done their presentations. So I'm now very pleased to introduce Kim McClellan, who's president of the RRPF Foundation based in the United States, who's going to talk to us about RRP as a different perspective. So thank you very much for joining us, Kim, and over to you.
Good morning. Thank you for having me. I'm going to continue the conversation that we've already started on RRP and why it really is the overlooked HPV disease with a significant burden to the patient and also the healthcare system. As we've already discussed, RRP is caused by HPV 6 and 11. But what we haven't discussed yet is that this also has a notable cancer risk, especially when it is in the lungs. And it impacts boys and girls. Surgery is often into the 100s. In the US, we have a new FDA-approved drug that treats the root cause of this disease and has shown results in about 51% of patients. We also are seeing the uptake of the use of bevacizumab systemically to control the disease, but it is not a cure. And when you stop the drug, the disease comes back. More importantly, this disease is preventable. This is a rare disease that we already have the tool to prevent, and that is by using the quadvalent and the non-valent HPV vaccine. Why does the type of HPV vaccine matter? The bivalent does not protect against HPV 6 or HPV 11. In the countries that are only using the bivalent vaccine, they are leaving their entire population at risk of juvenile onset and adult onset RRP, preventable rare diseases. In those countries using the quadvalent and the non-valent, as was just shown in the presentation before me, the incident rate, especially of juvenile onset, is at a dramatic decrease. We have the tool to eradicate this disease, and it's important that we know that every country is using the quadvalent and the non-valent vaccine. When we talk about living with RRP, it's not just surgery. Just in the US, 41% of patients are traveling greater than 100 miles for care. In the US, because we don't have government-funded health care, 61% of our families are spending more than 5% of their household income on RRP care. This doesn't even go into the fact that all these surgeries, all these doctor's appointments cause your child to miss numerous days of school. You may be missing numerous days of work, depending on where you work and what your absentee policy is. You can lose your job because of RRP. The thing that's not discussed that we need to talk about is that a lifetime of surgery is not normal. 45% of RRP patients report depression because of this disease. When we talk about the cancer risk, we're really focusing on lung when it spreads to the lungs. In the lungs, it is a 32 times higher risk of malignant transformation compared to laryngeal disease. We know juvenile onset tends to be more aggressive. We know type 11 tends to be more aggressive. We also know that these pulmonary lesions can progress to squamous cell carcinoma with a very high mortality rate. Screening is currently not part of the standard of care. but distal spread of this disease is a major concern for patients. I want you to take a look at this picture. And if you were a clinician looking at this and you did not know this patient had RRP, you would assume this patient had lung cancer. So what we do know in a recent study, of those patients with lung involvement, 85% of them were juvenile onset. 34% of those went on to have malignant transformation with a 16% mortality rate. We're still hearing the conversation that HPV-6 and HPV-11 are low risk. I'm here to argue that that's wrong. There is nothing low risk about the data on this slide. RRP is not low risk, and we need to change how we talk about it. We also need to go and be more aggressive at pursuing non-surgical treatment options, because even one surgery can cause irreparable damage to the mucosal layers of the airway. Every surgery has cumulative damage, which impacts the quality of life of the patient, which means that patient isn't living their best life, which is what we want to avoid. So even one less surgery matters to patients. So again, this is preventable. It has significant patient burden, a real cancer risk, and RRP matters. We're not low risk. The foundation has been very proactive as of late, working to establish quality of life measures, standard of care algorithms. 3 recent publications that we're part of. One was we took our patient registry data and we showed the patient perspective of living with recurrent respiratory papillomatosis. And I shared some of that data in an earlier slide. We've also done a clinical consensus statement on pulmonary RRP, which argued over the importance of screening for pulmonary spread of the disease. And within this paper, there is a screening and treatment algorithm. Most recently, we worked to create a position statement with KOLs across the US on how to manage adults with RRP in this new era of RRP treatment, where we have systemic therapies that patients can access. We have an FDA-approved drug that's now being in the process of getting that drug to Europe. So the time is now to change how we talk about RRP, how we treat RRP, because what's better than a patient having successful surgery is a patient never having surgery. And with that, I thank you for having me. I'd love to answer your questions. Feel free to contact us through our website. And I hope you have a great day. Enjoy the rest of this webinar.
Thank you very much indeed, Kim. A fantastic presentation, and it is really important that we know more about the impact on quality of life from RRP. That's really important. Thank you. And also, I've been working in the HPV policy field for quite a long time now, and I'm embarrassed to say I didn't know that RRP could actually lead to cancer. I just didn't know that, and I think that's really important information. So thanks for sharing that as well. But we'll come back with some more questions for you later. So thanks for now. And I'd now like to introduce our final speaker, Samuel Anyula Gorigo, who's joining us from Kenya, who's going to talk about his work on genital warts. So Sammy, over to you. Please share your presentation and go right. There we go. We can see your presentation now. So please go ahead.
Good morning, good evening. So today I'll be sharing insights from our clinical and advocacy work, what we've been doing from community work on HPV-associated anogenital warts in men, majorly gay, bisexual, and other men who have sex with men, male sex workers, and men living with HIV, focusing on real-world experiences, system gaps, and opportunities for prevention. So this is an overlooked burden. So in many settings, HPV is largely framed around cervical cancer and as women's issue. However, in our clinical practice and community work, we are seeing a significant and growing burden of HPV-related diseases among men, particularly anogenital warts, anal diseases, and also continued transmission. So these are just clinical reality. These are some of the images, some of the anogenital related conditions that we see on our daily basis. So this is what we are seeing in the clinic. At our facility, many clients present with advanced anogenital warts or lesions requiring surgical intervention, an indicator of systemic gaps in early detection, prevention, and also access to care, majorly driven by stigma and discrimination. So these are some of the images, some of the conditions that we see. These are advanced anal warts and advanced genital warts. So beyond the physical symptoms and lesions, there is also the human impact. These conditions are not just minor or cosmetic. They also have a profound impact on quality of life just across the physical, emotional, and social domains, mainly majorly affecting dignity, relationships, intimacy, and also mental challenges. So where the system falls short, the challenges is not the absence of disease, but the absence of system designs to detect and or manage or prioritize it. There are no routine annual or HPV screening programs for men, especially the high-risk groups of men and boys. My colleague Peter had shared like men who have sex with men living with HIV, male sex workers at heightened risks, especially when it comes to HPV-related diseases or symptoms. We also have limited provider capacity, poor integration into existing programs such as HIV and sexual reproductive health programs, and also weak data visibility, which make this burden largely invisible. So why men are not reaching care? There are barriers and challenges. So stigma and discrimination, particularly high-risk groups for key populations, remain major barriers to care. So what happens, many clients delay seeking services due to fear of judgment. There is also low awareness and also financial constraints, often presenting only when disease has progressed, as you have seen from the previous slides with the images that I've just shown. Those are some of the daily things that we see in our community clinic. So despite all those, we also have opportunities. There are things that we have tried to do and also to advocate. So from our community work, our advocacy work has been mainly around promoting and advocating for the integration of HPV services into existing HIV and sexual reproductive health programs. The reason why HIV in Kenya, there's a specific program for key populations around HIV and also sexual transmitted diseases, and HPV has been classified under STI, so it's within that programming. So one thing that we've been trying to do is just to advocate around just integration and promotion of HPV services also to be extended to boys and men. We have also co-created Kenya's first annual health SOPs and also HPV screening tool for boys and men, which has been endorsed by the Nairobi County Health Management Team. In Kenya, health is a devolved function. That's why I'm talking about the county. We also held a meeting at the national level whereby the tool was reviewed by the National Cancer Institute of Kenya. We have also engaged communities just to better understand what are some of the barriers and drivers towards uptake to HPV services. And these efforts demonstrate a strong foundation that is already trying to build or in existence. And what is now needed is just to scale and also just a wider implementation. So HPV prevention is incomplete, and the reason why I'm arguing the HIV prevention is incomplete. So the current HPV prevention strategies remain incomplete as they largely focus on girls while excluding boys and men. So this approach sustains transmission as it is evidently from the population that we are seeing, sustains transmission and also limits the overall impact of prevention efforts, resulting to ongoing disease burden as we have seen. So the call to action, what needs to change? To effectively address HPV, we must adopt a more inclusive and integrated approaches, which include implementing gender-neutral HPV vaccination and also strengthening integration of HPV into some of existing health programs such as HIV and sexual reproductive health, which has been a platform from Kenya as a best practice. That is what we've been doing in part of our advocacy, trying to advocate for that HPV to be integrated into those existing programs because there's already a framework for that. Also, it's very important investing in provider capacity. The reason why we are receiving advanced cases because most of providers do not have that adequate knowledge that HPV is also an issue that can also affect men, especially the high-risk groups of men, such as MSMs, men living with HIV. So you get diagnosis is always done at a delayed presentation. We also need to include HPV in policy frameworks. So addressing HPV in men is not only just a clinical priority, it's very essential for achieving equitable and also an effective public health outcomes. So we are part of the work that we have done. We've also done publications. I had forgotten to attach some of the publication, but I'm just going to attach them in the chat box. We have done 3 publications. One is towards integration of HPV into existing prevention programs such as HIV and sexual reproductive health. We have also done a case study, like a patient's journey, like trying to track how patients comes, how they get services until the recovery of their symptoms, especially the one presenting with advanced diseases. Yes, thank you.
Thank you very much indeed, Sami. A very powerful presentation, and I think you showed very clearly just how warts is not by any means not a cosmetic issue. It's a serious public health issue that needs to be addressed, and you made a very good case, I think, for gender neutral or routine universal HPV vaccination, and that really is the only way to protect men who have sex with men against these infections. And it's important, of course, for all men and boys. So thank you very much indeed to all the speakers. Perhaps if you'd like to come or switch your videos on and join me, I can then start putting to you some of the questions that have come through. We've had some really good questions in the Q&A box, and if you haven't asked a question yet and you'd like to make a comment or ask a question to any of our speakers, please feel free to do so. So the first question we had was that a comment and a question, I think this is probably for you, Riaz, about adult onset RRP. You said that adult onset RRP is sexually transmitted, but is that the only cause of adult disease?
Well, it could also possibly be due to reactivation of latent HPV infection, but it's mainly thought to be sexually transmitted, the adult onset form. Okay. So we also have children that have juvenile onset RRP that continue to have the disease into adulthood, or who initially go into remission and then have reactivation of their RRP in adulthood.
Okay,
and then, so can I also just address the issue about there was a question about the vaccination and the juvenile onset RRP. So the main benefit of vaccination on juvenile onset RRP is preventing the mothers from getting the HPV infection before they give birth, which is how we prevent the babies getting juvenile onset RRP. So the effect on the incidence that we've seen usually occurs 10 years after the introduction of the HPV vaccination, because that's when the mothers that have been protected are giving birth. So it's not, although there is some data on using it as a therapeutic modality, the main effect is on prevention of the mothers getting the HPV infection, so that they don't pass it on to their babies when the babies are born.
Okay, thank you. Kim, you were shaking your head. Did you have a thought about this one as well?
The thought process as far as adult onset, and he actually said it, is that it's either through sexual activity as an adult, or the second thought is dormant disease from childhood that's activated into adulthood.
Okay, thank you. Another question on RRP from Deborah Watson-Jones. What is happening with adult RRP and oral sex as a risk factor? Is adult RRP increasing? So we see, presumably oral sex is the main risk factor. Is that right? And is it increasing because of the increasing prevalence of oral sex over the last 40 or 50 years?
Okay. Well, it's thought to be a risk factor. I don't think there's definite evidence for that. But interestingly, I haven't come across any data on any changes in the incidence of adult onset RRP. But I mean, I think in my setting, we see very few of these cases. It appears to be much more common in Europe than sort of in the developing world.
Okay, thank you. Kim, any thoughts on that one?
I think we also need to, go back to what was said in the prior presentation, and that, we do see this peak now in the later life of adults. And think about it, those are adults who were never given the HPV vaccine, who are now in their 60s and 70s, who've been exposed to the virus for reasons such as new sexual partners, or, they've been divorced, remarried. So, that's where we're seeing an increase in adult onset, is in that older population. Or we are seeing a decrease in the younger patients because they are vaccinated. So that's why it's so important to vaccinate children, is you're also protecting them from getting the virus later in life as they become sexually active.
Okay, there is obviously now a conversation and a discussion about the merits of adult HPV vaccination up to the age of 45. And it certainly sounds like from the RRP perspective, there will be some value in that.
Yeah, because you may not have been exposed to that particular strain of virus.
Yeah.
And it would protect you from that had you not been exposed.
Yeah, okay, thank you. So let's move through the questions here. Okay, from an advocacy point, this is an interesting one. From an advocacy point of view, by focusing on one gender, are we limiting the overall objective of increasing HPV vaccine coverage? So basically, this is a question, I guess, about whether we should be focusing on routine universal or gender neutral HPV vaccination rather than just the vaccination of one sex. And perhaps I could bring Sammy into this conversation as well, because you all referred to the importance of gender neutral vaccination. So I assume this is something that you're all in favour of and you feel would benefit everybody. Sammy, do you want to come back on that one?
Yes, Peter, I didn't get the question, sorry.
The question is really about whether we should be talking about single-sex vaccination or vaccinating everybody, all boys and girls, and whether the only effective way of protecting the whole population against RRP, warts, and of course the cancers caused by HPV is through universal vaccination.
Okay, thank you. So I think the best direction is to focus for what we are advocating for HPV gender neutral vaccine, because from the population that we are serving, we have seen that men having sex with men are not protected because you see, for example, someone could be arguing like for the heterosexual population, they could be protected from women who have been vaccinated. But we have also seen men and boys are also affected by HPV-related diseases or symptoms. So the best approach is just to universally vaccinate everyone, including boys and men, because we have also seen HPV-related symptoms or cancer also affecting men.
Okay, thank you. Kim, Riaz, do you want to comment on that as well, that question?
You know, we all know HPV is an equal opportunity virus. And we have spent so much focus on cervical cancer, and now we know that HPV is causing other cancers, and we know it causes RRP, and those are not limited to just women. And so we need to protect both boys and girls from this virus. So universal vaccination for boys and girls is the only way to go.
Okay, thank you. An interesting question as well about whether we should be giving HPV vaccination at birth. Could that protect against juvenile onset RRP, if that were possible?
Well, as far as I know, there's no data on the immunogenicity or safety of these vaccines in children under the age of 9. So I'm not sure if we would be able to do that.
Okay. You're on mute, Kim.
And we also know that this virus can be transmitted in utero.
Okay, so it probably wouldn't work even if we could do it vaccinations at birth. Okay. Okay, another quick question here from Heather Cameron. HPV DNA has been detected in urine samples. Is there any current evidence for urine-based HPV testing as a non-invasive screening or monitoring tool for RRP? And do you see this becoming clinically viable?
Well, in RRP, the HPV is confined usually to the larynx. It's not a systemic infection, so I don't think it would be feasible to test the urine.
Okay.
There are some papers on testing the saliva for HPV, but sort of these are very early studies. But usually most patients, they'll present again with hoarseness as sort of an early symptom, and usually that would be the indication for us to operate again. It's usually it's usually symptomatic, the detection of the recurrence.
Thank you. Can I ask a question about the cost of RRP in terms of, well, not only the treatment, but also the wider social costs? Because Kim, in your presentation, you talked about people taking time off work and time off school, and all of these will have a financial impact on individuals. But do we have any kind of assessment of just how much RRP is costing health systems?
I do know there's been a study on that, and I don't have that number at the top of my head right now. And that's going to be very country dependent, depending on whether or not your country has government funded health care.
Yeah.
And so, what may be true in the US is not going to be true, say, in the UK or Canada, where they have government based health care. But in the US, it is a significant economic burden to the patient and their family. But it is going to be country dependent.
Mm-hmm. Riaz, do you have any data from South Africa on the cost of RRP in terms of treatment and wider social and economic costs?
No, I don't. Well, I don't have any figures. I don't think it's really been studied that much. It also has to do with how aggressive the disease is, how often they need to go for surgery. But I mean, it is a considerable burden on the patients and their families because, especially, I mean, we have mostly children with RRP, and it's involves the mother taking time off work. And I mean, I work in the public healthcare system, and many of our patients sort of travel a few hundred kilometers to get to us. So it's not just the cost of the surgery and hospital admission, it's sort of a lot of the social cost as well, with getting here, taking time off work and time off school as well.
Okay,
Which is
thank you.
why it's so important that we move to these therapies that treat the disease systemically so we can move away from surgery and make it to where every country has access to those therapies.
Can I perhaps turn from the, well, sort of perhaps more sort of the aspects we've been talking about to the policy dimensions of this? Because clearly, if my perception is right, in terms of how we talk about HPV policy and vaccination policy, we talk primarily about cancer and the impact of vaccination in terms of preventing cancer, and also, of course, how to screen for and treat HPV-related cancers. But warts and RRP are not usually part of the discussion. What do you think, from your experience with these diseases, what can we do to push RRP and warts up the policy agenda, to make them more recognised in the policy work that we do and in the advocacy work that we do? Sammy, would you like to have a go at that first from your experience in Kenya? How can we make this much more, give this a much higher policy profile, do you think?
Yes, thank you. From the clinical experience and also the community experience that we have done, what we have been doing is what we call evidence-based advocacy. So HPV vaccination should not only be discussed as girls or cervical cancer issue, but also as a broader cancer prevention tool that can also benefit men, including people affected by anal cancer. Something that we have been seeing, because the population that we are serving is mainly for men and high risk groups of men having sex with men, male sex workers, men living with HIV. So from a policy perspective, most national guidelines have prioritized vaccination before exposure, usually in early adolescence, and many countries only few allow catch-up or shared clinical decision-making just around 45 years. So what we have done from our country, here in Kenya, health is a devolved function. So what we did, we are trying to engage the county, and we are sort of tracking the cases that we are seeing, because we also don't have indicators around that tracks HPV in men. So making evidence or making the data, when there's no data, sometimes programming becomes a problem. So what we are doing, we invented our own indicators as community programs. And these are some of the tools that we are using just to elevate our advocacy to the county and also to the national level, whereby we're engaging the National Cancer Institute of Kenya about these issues, trying to show them, like, see, this is the information that we are having. We understand the focus, the perspective has always been geared, and the focus has always been geared towards women and girls, but we also have these populations here of men and boys that are equally affected by this disease or infection.
Thank you. Kim, you obviously work for an advocacy organisation. So what's your experience of trying to raise these issues in policy and trying to get policy change?
One thing we've done as the foundation, or several things that we've done, is we've pushed this conversation into the cancer circles, whether that's, the NCI in the US. We've also worked with regulators and elected officials to bring awareness to this disease. We've joined things such as the American Cancer Society National HPV Roundtable. We've spoken around the world to raise awareness of RRP within the HPV community at conferences such as IPVC and Eurogen. What we have found is that a lot of this is lack of awareness and lack of education to the seriousness of the disease and its real cancer risk. And so that's what we're doing as an organization, is elevating that conversation in circles where it hasn't been before. Because we know otolaryngologists and laryngologists are aware of the disease, but we're learning that primary care, pediatricians, gynecologists, they're not aware of the disease. And so educating them is going to help with the awareness as well. And working with our patients around the world to educate them about the disease so they can tell their community about the disease in a factual manner.
Okay, thank you. I guess also, what would also always makes an impact is having people who have lived experience of the disease talking about their experience publicly. And I guess that's something that you do, Kim, and your foundation does quite a lot. Yeah.
We do. I mean, we're all about elevating that patient voice and that patient experience. And that's why we've, written the papers with the emphasis being on the importance of moving away from surgery, especially now that there is an FDA-approved drug and we're seeing such dramatic results with systemic bevacizumab, and getting that awareness out, because as has been discussed, the amount of travel these patients are taking to get expert care for RRP, to get qualified surgical care. If we could do a systemic treatment in a local office, that improves their quality of life and it eases the economic burden to the patient and their family.
Yeah, thank you. Riaz, any thoughts on how we get this issue in front of policymakers? What's your experience in South Africa? Do you think that policymakers in this area are interested in warts, RRP, and as well as cancer?
I think it's more the cancer. I think, sort of in the developing country, there's many other more important health conditions. So we do try and raise awareness as much as we can, but it's sort of still a rare, even though it's life-threatening condition. And I think by advocating more for effective cancer vaccinations is the way to get the HPV vaccines.
Yeah, okay, thank you. Please keep asking your questions. I'm going to try and come to as many as I can. Let's see, I'm trying to pick a question that hasn't been covered by the answers so far. Do we see any changes in RRP rates in countries that have girls-only vaccination versus universal vaccination programs? I think you touched on that, Riaz. I think it was in your presentation. You talked about the situation in New Zealand, which I thought was interesting, where even though they have universal vaccination, the rates haven't come down. The rates of RRP haven't come down as much as you would expect. But in other countries with gender-neutral programs, the rates do seem to have come down more sharply. So I guess we do have some data. But is there anything you'd like to add about that?
Well, I think the initial fall drop in Australia and the US was also with only female vaccination. I think the issue in New Zealand is, firstly, the low incidence makes it difficult to detect a decrease in incidence, but also, although the vaccine is available, it's getting people to take the vaccine as well that is the problem, because I think they said it was sort of less than 70% coverage of females in New Zealand with vaccination.
Okay, thank you. Question for you, Sammy, about sex education in schools in Kenya. Is that something that's available in Kenyan schools?
About sexual educations, currently is not actively, but there's a bill that was taken to Parliament whereby they wanted now to introduce a bill on what we call comprehensive sexual health education to be part of the school curriculum program.
Okay, thank you. And also, while you're there, Sammy, in terms of the discussion about gender-neutral vaccination in Kenya, is there any sign that the Kenyan government might be open to that?
Yes. Part of the advocacy that I was doing with my organization was just to also make sure that boys and men have access to the HPV vaccine. The vaccine is licensed for both boys and girls in Kenya, but the problem for boys and men has always been accessibility. So it's not accessible for boys and men, especially within the mainstream public health facility, but it's only readily accessible to girls. So when we are having our advocacy meeting, so we had a meeting with the head of prevention and promotive at the county level. So what she was telling us, like it is an issues of procurement and also it's an issues of cost. So that is some of the things that she was telling us, like those are some of the things that we really need to coin ourselves around and see how we can navigate that. And then there's
Okay,
also a question that I really wanted to respond to. I think it was asked by Stanislaw. It was about pathway in healthcare system for genotyping of HPV strains in men. So in most setting, this is just some of the current reality, including in many high and also middle income countries. There's limited routine or what we call standardized HPV genotyping, a pathway for asymptomatic men. Because HPV testing in men is not widely available, or there's there's limited recommended clinical guidelines around that. And this normally exists, especially where we normally have research or specialized clinic that involve penile, urethral, or anal swabs, but results are often difficult to interpret clinically. And this is the case because HPV infection in men is often transient, and sometimes it can clear spontaneously. And also, there is no or limited approved screening program for HPV in men equivalent to cervical screening in women. So this makes testing, sometimes testing does not reliably guide clinical decisions in asymptomatic men. Yes.
Okay, thank you. Just one final question for you, Sammy, as well. You mentioned in your presentation about the criminalization of homosexuality in Kenya, and of course that's the case in many countries. I think over 70 countries around the world, homosexuality is illegal. Could you say something about the impact of that in your work and how that affects men who have sex with men seeking care and treatment for HPV-related diseases?
Thank you so much. That's a good question. So Kenya is one of the countries that has criminalized same-sex relationship. And one of the things that we've been seeing with criminalizations. So what criminalization does, it creates an environment where there's fear. It also creates an environment whereby stigma and discrimination is easily perpetuated. So what we've been seeing as a result of this, most clients do not present to the clinic at an early level. So they normally present at advanced level. And some of the cases that I represented, some of those images, those are images that we take from our clinic. These are things that we see on a daily basis. And we're the only organization in Kenya that offers a comprehensive HPV package to men in terms of screening and also in terms of trying to offer surgical need for those that needs surgical. So criminalization has a very bad impact because what it does, it deters people from seeking care on a time level because there is that fear. What will happen when I go to the facility? And then also in Kenya, HPV has been widely publicized as a women's health issue. So when what we are doing, what we did, we decided to have sessions with community members, and we really wanted to understand what are also some of the reasons away from stigma, away from fear, and also the criminalization. What are some of the reasons that also makes them not to present early to the facility? Some of the things that they were telling us is lack of awareness. Like they were not aware, like where they could go and get these services for HPV for men. And also the knowledge, like they didn't know what exactly was happening to their body. So the only time they could present themselves is when the disease has advanced. It's now causing problem and difficulties in their daily life or routine.
Okay, thank you very much, Sammy. Obviously a really, really important issue. I'm afraid we've run out of time, so we can't take any more questions. And I'm sorry if we didn't come to your question. Before we wind up, I just wanted to share with you what our plans are for future activity in this area. So just bear with me a second while I reopen my slides. I hope you can all see that. So the work that we're doing at Global Action with NOMAN is an Island will obviously continue. Please sign up for our quarterly newsletter if you don't already receive it. We share information on a regular basis about our work and about news in the field. So it really is a good source of information about men, cancer and HPV, but obviously not just about cancer, but about other issues. And we are going to, in the light of this very important webinar today, make sure that we take more account than we have done of warts and RRP. We'll be please endorse our call for global routine universal HPV vaccination. We're inviting organisations to endorse the call and to add their support. And in the website, you can see there endhpvglobal.org. you can see who the 70-odd organisations that already supported our call, and you can fill in a short form to add your organisation's name to the list. We're hoping to publish a paper in the Lancet Public Health later this year. It's been accepted subject to review. This will be a position statement on routine universal vaccination. We'll be asking organisations and individuals to support that. So please look out for that. Please do join us at events throughout the year. We're going to be at the World Health Assembly in May, in a few weeks' time. We'll be at the IPVS conference in Athens later in the year, the Global Cancer Congress, and at the WFPHA Congress in South Africa. But we'll be sharing more information about where we'll be and what we'll be doing at those events through our newsletter and in other ways. So please do what you can to support global and national advocacy for boys' vaccination. If you like, you can join our Men's Lived Experiences Advisory Group and watch this space for further webinars and activities. We'll be having at least 3 more webinars this year on men, boys and HPV. It is World Immunisation Week. I should have said that at the start. That's why we're holding this webinar this week. So please do what you can to support World Immunisation Week and make the case for routine universal vaccination. And these are some of the organisations that are supporting our call to action. So, as I said, if your organisation would like to support this as well, please let us know. And if you'd like to evaluate this webinar, which we very much welcome, please use the QR code you can see, or if you've got time to write down the email address, we'll put it in the chat as well. Perhaps the easiest way is to use the QR code. There's only 6 questions. It will take you just a few minutes to provide evaluation about this webinar. Please read our report on boys, men and HPV. Let us have any feedback on it, because we're going to revise it in the next few months. So any comments or feedback about the report will be very welcome. So I'll just leave the QR code for the evaluation on the screen. So it remains for me, only remains for me to thank our speakers, Kim, Sami and Riaz. Thank you for your excellent presentations, really informative, and we'll make sure that what you've shared with us and what our audience has shared with us will be reflected in our work from now on. And thank you all for joining us. It's been fantastic to see so many people at this event. And as I said, we'll be sharing the video of this through our YouTube channel and on the Global Action website. So for now, thank you very much and goodbye.